Dr. Ramesh, please.
Good morning again. Thank you, Dr. Azam, for the kind invitation. Shall I connect mine? Or? So while we get connected so that we won't have any issues with the audio visual. This one. So this is a great meeting. I think the quiz actually is really going well. I think many people should be participating, and we have about nearly 300 people, it looks like, in this room. For the next two sessions, I think we should encourage everyone to participate on that. Yeah. Use swap displays. Okay, no. Okay. 1 minute. It should be the other way, no? Swap displays. Yeah. Okay, so we'll start. Thank you very much again, and I have no disclosures. So let's start with two cases. 60-year-old hypertensive, cardiac arrest at home, return of spontaneous circulation after one round of AP, and CPR pH is 7.2. Dr. Fiesby and I were talking about it, these patients, that our youngsters want to take everyone to the cath lab because we are now interventional cardiologists, right? And we want to take them to the cath lab and perform everything that we can because we think that otherwise these patients are going to die. So the EKG, you saw that. And what is the next best step? I think you can say cardiac catheterization or medical therapy, hypothermia, or all of the above. Dr. Guzman gave a fantastic talk about STEMI. This is probably, you need to see that all of the above is probably the correct answer in this patient. So you take the patient to the cath lab, as you can see that there's a three-vessel disease, left main and ostial RCA. There is a significant amount of disease. So what do you do now? Either pH is 7.2. My cutoff is actually less than 7.2. So I don't think anyone with less than 7.2 have a likelihood of survival. And the longer they are in low pH and acidosis, I think it is better to actually just comfort the family and call it a day. And this is the LV ejection fraction. It is very low that you can see. Now what? A balloon pump, impeller, ECMO, all of the above? None, just inotropes. I don't think there is any right or wrong answer here. You can choose whatever you want, and depending upon what your facility has, and as I mentioned, how long has the patient been in shock. So a patient obviously is in the United States, so he gets an impeller. Impeller is quite expensive. It is not available across the all over the world, and only in certain countries, and even in the UK when it was released. There was a limitation on number of impellers that could be used in that center in a year. So they have to pick and choose which patients, but that's not in America. Everyone can use it. It is easily available. And so this patient had a impeller placed, and the PCI of all the vessels was performed, complete revascularization. But he remained hypotensive. ECMO was placed afterwards, but he was continued on high-dose DOPA and AP, nor-AP, amio, and he developed renal failure, remained acidotic, ischemic leg. These are all the complications that you'll come across when you try to do these patients or be heroic measures in such a cardiogenic shock. He was transferred for heart transplant because he is young. At transplant center, he was reevaluated and made comfort care, and he died 3 days after cardiac arrest. So this is one patient that I want to present. Here is another patient, 47-year-old diabetic antiphospholipid antibody on rivaroxaban, develops anterolateral MI, loaded with ticagrelor or primary angioplasty was done, LAD stent was placed, and TIMI-3 flow. This is probably a routine for most of us when we don't use intravascular imaging as much. 1 hour later, a patient develops a VFib arrest, refractory to DC shocks, ongoing CPR. We have something called Lucas or autopulse, and that was placed and patient was brought back. As you can see, there is complete occlusion of that LAD stent, multiple shocks, VF then asystole. So obviously it's probably an undersized stent, underexpanded stent, missed dissection. All of that could have been avoided if imaging was used. And so as you can see that underexpanded stent and probably some dissection. So that was ballooned and a patient was placed on ECMO again because of poor cardiac output. And so on day 1 to day 22, you can see that patient all again suffered kidney injury, liver injury, and gradually some contractility was observed on echocardiogram, and ECMO was decannulated and balloon pump was placed, and still had distal embolic events from the balloon pump. But after 22 days in the hospital, full neurological recovery and LV function 40%. So these two different patients, 47 and 60-year-old, and I think you can see that how the patients have survived. And the most important thing is we don't know which patient should we do all these, including heart transplant, or which patient actually should we say that enough is enough, this patient is not going to recover, and that is where the art of medicine. Do not worry about artificial intelligence. Artificial intelligence is never going to replace cardiologists because we ourselves don't understand clearly to feed the artificial intelligence computers. So traditionally, the shock is defined as systolic blood pressure less than 90, diastolic blood pressure less than 60. Where did we get that from? They let actually 6 dogs bleed and said what is the blood pressure that below which there is some damage to the cells. So that's how we came up with 90 over 60 is called hypotension or cardiogenic shock. So this has to be secondary to cardiac dysfunction, not from bleeding the dogs, and associated with signs of hypoperfusion such as cardiac index less than 2.2 or wedge more than 15 and a wedge more than 15. So as I said, shock is variable, and that is why Sky actually came up with bringing everyone together and trying to understand. Because IMPRESS trial is the first patient that I presented, which is a patient with a VFib arrest with a pH less than around 7.2, and there is obviously much worse than IABP shock 2 trial, where actually people were at least having some urine output and pH is not is above 7.2 and not less than 7.2. So one size does not fit all, and the lack of common knowledge has impeded the advancement of research on optimal diagnosis and management of these patients, and we are still trying to learn. So this is Sky stages of cardiogenic shock. A means at risk. Any patient with acute anterior wall MI is considered as at risk for the cardiogenic shock, or even RV involvement as well. And B is beginning, meaning patient's blood pressure is soft. He's only at 95, or occasionally comes below 88 or something like that, systolic blood pressure. You need to be concerned about that. C is classic shock. That means they are below 90 over 60 for at least 10 to, for 30 minutes. And you need to actually start him on 1 hour pressors and fluid challenge. Still, patient remains in shock. That is stage C. Stage D is dual pressors. If somebody is on 2 pressors, you can consider as stage D. Extreme is despite all the efforts that you do, patient still remains in shock, and you can add cardiac arrest as a modifier to any of these patients from B to E. So based on A, B, C, D, E, there are some clinical parameters that you can look at, some hemodynamics that you can also look at. If anyone has a cardiac index less than 1.5, you should consider that actually is already in stage E shock. So what does it matter? How, as I said, IMPRESS trial and IABP shock 2 trial, they're different. And is stage A and stage E, these two different shock stages, does it make any difference? Yes, absolutely. You can look at the mortality. A stage A patient actually has probably 1 to 2% mortality. Stage E patient has about 60% mortality. And depending upon these stages, and they have also studied that how many pressors we use, number of drugs in the upper corner, and there are a number of heart failure and mortality. All those are affected by the stages of shock. So the therapeutic goal in acute MI and cardiogenic shock is obviously stabilizing the patient, reperfusing as fast as possible, minimize stunning, and that is stopping myocardial injury and enhancing myocardial recovery, restore the normal myocardial metabolism, and prevent reperfusion injury. Several devices are available, as we said, balloon pump to ECMO, tandem heart, and impeller or surgical VAD. Many of these may not be available in every center, but one thing that's available in every center is a balloon pump. I would definitely encourage using it, even though the data shows against it. But I think at least something can be done, and it gives a 0.5 liters of cardiac support at least. So this is a complex patients like what we were talking about, and all these patients may not survive. The unloading of the left ventricle, as discussed earlier, is very important in acute MI with cardiogenic shock. And how do you know whether it is cardiogenic shock? Is based on the pulmonary artery catheter. If you don't put a PA catheter, you will never understand. Even though the critical care data by ESCAPE trial showed that PA catheters can cause some complications, but now there's a revival coming back at using PA catheters in cardiogenic shock. So left ventricular load is bad for acute MI. Kapoor has shown this clearly that there is increased mortality if the LV end diastolic pressure is more than 24 in ST elevation MI patients compared to a EDP of 12. So you know that we don't have any randomized controlled trials to support using any of the devices in cardiogenic shock right now, whether it is IAPP or IMPRESS trial with impeller or VA ECMO, and any of the impeller randomized control trials are not actually existent. So there are several algorithms that come out, and I can show you that there is no simple single algorithm, but they definitely now made an impact towards National Cardiogenic Initiative based on SKY shock stages, actually reporting a lot of benefit using devices early. So measuring the performance in circulatory support can be done by this, usually you can use this app actually, but also you can use it by cardiac index as well. If you place on ECMO, you can see that the pressure volume loop goes to the right, which increases LV pressure, aortic pressure, but also increases LV end diastolic pressure, which is not good. So they need venting. And once you put them on ECMO and then put an impeller, the curve now shifts to the left, which actually reduces left ventricular end diastolic pressure. That can be done with a balloon pump as well. So unloading the left ventricle in an impeller patient is important. So this is our algorithm, but I can share that with you. But what we did in our center is anyone who comes with a shock with more than 30 minutes of shock, immediately they get a swan in the cath lab, and based on the cardiac index, if it is less than 1.8, they get an impeller. Between 1.8 and 2.2, they get a balloon pump. If it is 1.5 and less, they get a tandem heart or a 5.5 impeller. So with that, we were able to show that mortality can be reduced from 44% to 28% and 24%, and this is predominantly by using impeller in our center. The number of cardiogenic shock cases are on the rise, but the mortality actually observed to expected mortality is much lower with using this type of algorithmic approach. And also, obviously, PA catheter will help. So I think you take home points wise, prevent patient from going into refractory shock. Don't wait and sending the patient to a different center. Send them right away. Early initiation of PA catheter will help you improve survival. Quick escalation. If the patient remains in shock after balloon pump for 30 minutes, immediately send the patient to an ECMO center if you can. Or in India, what they've done is they put two LV catheters in the left ventricle, and they actually use that to unload the left ventricle as well. So that has been done. With that, I'll stop here, and I'll take any questions at the end. Thank you.